So I have used all kinds of unicondylar knees in last 16 years, fixed, mobile, gold, black, cobalt, chromium, medial, lateral, conventional, navigated, robotic, and really I can tell you, as you already know, all UKs are not the same, and I love robotic UKR because I think robot is ideally suited for total hip replacement and partial knee replacement, because the total knee really I'm not convinced, because I don't know what you're shooting at. So they just keep on, everybody has his own philosophy about alignment, but that's not so in THR and UKR. So that's, if you need to use a robot, these are the indications. And then this is what the problem is, he is my younger brother. And only character I know in Hindu mythology who can pitch a brother against brother is this guy. So, that he's pitched a brother against brother. But anyway, I'll go on with my karma and go ahead with what I have to say. So first thing is that the conventional fixed bearing UKR has proven track record, 97% survival at 12.4 years. The mobile bearing has 20-year survival of 92%. And then this is the Australian registry, which shows that, if you look at this, don't go for the busy slide, that's the fixed bearing modular UKR, which has got the best survival. The same thing being said here again. And we published this because there's a lot of talk about alignment. So when it was the issue about fixed bearing and mobile bearing, we navigated the same design UKR, fixed and mobile bearing, and we controlled the component alignment by navigation, and we found that there was no difference between the fixed bearing and the mobile bearing. Now, it's being said that it's important for alignment. So you have to be within 3 degrees. So that's the important thing, that you have to be within 3 degrees of varus valgus. So if you put your tibia in less than 3 degree varus and you have a change of tibial slope which is less than 2 degrees change in the posterior slope, there is excellent result with the partial. And then when it comes to Oxford, like, it's so forgiving, it's a spherical component. Because Ramneek did not specify fixed bearing versus mobile bearing, the Oxford is done conventionally only, and that gives you, look at the range, 10 degree varus to 10 degree valgus, 15 degree flexion of the component, 7 degree plus minus 5 degree of tibial slope, and tibia also can accept 5 degree of varus. So it's not, you can't dump all the partial knees together. Now there is a precision which has been enhanced by the newer instrumentation. You have microplasty, there are enough papers including the ones published by us where we have shown that the presence of the newer instrumentation system in conventional UKR has improved the results and the alignment. And then of course, so it's not that while the technology was advancing, the conventional instruments have not. But on the other hand, when you look at the robotic UKR compared to the 20-25-year follow-up being published in the conventional, you have only mid-term results available. Alignment is definitely better. Other outcomes are not different, and the survivorship is the same. So we admit that robotic UKR is more precise than conventional, but where is the advantage? Is it really advantageous in early phase? No, as this study says. And look at this in the Australian registry. Do you see a difference in the aseptic loosening between the robotic and the non-robotic? If anything, it looks that the robotic is slightly more prone to aseptic loosening. There are certain, while there is no clear early advantage, there are clear disadvantages, as Krishna also said. Higher cost, longer time, operating time, higher revision rates have been reported now. So that is the problem. Look at these codes, except for this KSS, all these codes in this study, robotic versus conventional, are inferior. And is it mistake proof? Look at this. This was bad planning. So if you do a robotic surgery with bad planning, it has gone into the ACL insertion, this underhanging there. If I won't do that with the conventional. So that is the problem. The cost is installation cost, training cost, increased time in operating room, disposable cost, and the most health insurance in India do not cover this. What about the radiation risk when you need a CT scan for planning? The time, the increased duration of surgery, you need intraoperative planning, registration of landmarks, and extra incision and pin placement. Now, this is a study of technology-assisted UKR. See, this is computer, not robot, but it says no significant difference in the risk of complication with longer surgical time. So should we just underplay the longer operating time? I'll just come to that. And then about the learning curve, that also was mentioned by Krishna, not just for surgeons, but assistants, nurses. The cosmesis, you have extra scars for the pin placement. And then the pin side complications, pin loosening, superficial infection, fractures, and other less frequent complications also can be there. Look at the operating room traffic. There'll be extra people from the company there'll be somebody managing the robot, somebody planning, and then somebody who scrubs. And then this is another paper from BJJ. 3-year survivorship of robotically assisted versus non-robotically assisted, higher rates of infection compared to the non-robotic. And then of course, if I am a high volume surgeon, I can actually just put 2 or 3 cases together, go from one to other. It's not possible to just move your robot around or buy multiple robots. So for high volume surgeons will be more reluctant to accept the robotic technology. And then like I said, when your femoral company is highly constrained mobile bearing Oxford, you don't need a robot for that. Although I would put condition to that, and that is, I feel that if you use robot and accurately equalize the spaces, then a bearing dislocation risk will become less. And this is the choice of implant. So when you do a robotic surgery, the robot chooses the implant for you because we don't have open platforms. But in a conventional UKR, you can decide whatever you have, and that's not a problem. So now I'll end this talk with the question for you. These both have been done by me. One is robotic and one is conventional. You'll be very hard pressed to tell us which one is robotic and which one is conventional. Whereas I know, so the one which is on your left is robotic. There was additional 75,000 cost. There was extra blood loss. The implant was chosen by robot. There was radiation. OT traffic was more. Risk of infection was higher. Pins were put and the operating time was higher. Thank you very much for your attention.